Bismillah ar-Rahman ar-Rahim. Hello everyone. Firstly, I would like to thank the scientific committee of the conference about inviting me to participate on this conference as a keynote speaker. I would like to also to thank Dr. Abdurrauf al-Manama about his sincere guidance and involving me in this important topic related to malnutrition in Gaza Strip after the war. Finally, my name is Mohammed Lulu. I am head of the Clinical Nutrition Department at Al-Azhar University of Gaza. My topic of interest is nutrition in emergency. I will discuss community-based management of acute malnutrition during Gaza war. The content of the presentation consisted of 6 sections, and the first section is defining the concept of emergency in general. By the definition, we can define emergency as a sudden and unforeseen events that call for immediate measures to minimize its adverse consequences, while disaster can be defined as a serious disruptions of the functioning of the society, causing a widespread human, material, or environmental losses which exceed the ability of the affected population to cope using only its own resources. Actually, here we can divide the disaster into two categories: slow onset disaster and fast onset disaster. But the condition in Gaza Strip where it is man-made disaster, where this is a small country, a small region in the Middle East, have changed the idea and it changed the mind of the world about thinking about the humanity and how can they participate in minimizing the consequences of this disaster. In Gaza Strip, we can categorize the vulnerability according to different aspects, where many of them matches due to situation and the specificity of the Gaza Strip. Vulnerable areas and the group can be categorized according to physiological vulnerability: infant and young children, pregnant and breastfeeding women, people living with chronic diseases. We can categorize them according to geographical vulnerability: people who live in areas that are subject to droughts or flooding, or in areas of conflicts, as in Gaza Strip. We are living in a small area in the region, in very crowded regions due to conflicts and due to the war. Their political vulnerability of oppressed population and their status as refugees or internally displaced persons, as occur in the Gaza Strip. About 90% of the population have forced to displace and to move from side to sides or from region to other region, just to save their lives and to match some of human aids that can help them to reach food or reach some of daily needs. Now we will move to the second section: food security versus nutrition security. How can we define the food security? According to the FAO, defines food security as a condition that exists when all people all the time have physical, social, and economic access to sufficient, safe, and nutritious food that meets their dietary needs and food preferences for an active and healthy life. This is the definition of food security. When we want to ask about food insecurity, we can talk about everything opposite to this definition. Household food security refers to specifically to food security at the family level, with the focus falling on the individual members of the household. That means we can have some of food for the family, but maybe insufficient for all members in the family. That means we have here household food insecurity, because the food is not enough for all members of the in the family. And the last definition here, we can define the food insecurity by a simple definition. The simple definition that means limited or uncertain availability of a nutritional, adequate, and safe food in socially acceptable way. Here in some regions and in some ways, we can have some of food, maybe according to our Islamic religion, this food is haram or forbidden, that we cannot use because this is not allowed for us as a Muslim to be consumed, like eating some types of meats that is not acceptable by the Islam. Here, this is not acceptable, not socially acceptable. Some of food may be taken by other population that is not usually used in this country. So this is not acceptable, and this is not acceptable food, not socially also acceptable. Because of that, we can find a lot of food, but not acceptable. In Gaza Strip, actually, we don't have acceptable or unacceptable food because everything has been limited in the resources, limited in food assistance, limited in the humanity assistance for the population. So food insecurity here means now we don't have enough food for everyone in the population. Now we can discuss the basic elements of the food security. The first element of food security is food availability, which is achieved when sufficient quantities of food are consistently available at the household level, regional or national level. National food availability depends on the domestic food production, commercial imports and exports, food aid, and domestic food stocks. Actually, during the Gaza war, domestic food production has completely disrupted, so a very limited food production can be returned from Gaza farms. Commercial imports has been also stopped completely because of the closure and the blockade around the Gaza due to Israel war and due to the Israel rules, how the movement from in and out the Gaza has been follow strict guidance and the strict rules by the Israel forces. And the last one is the food aid, where the food aid has been very limited amounts to enter the Gaza. Access to food, which is the second element of food security, pursues physical access and depends on the household's purchasing powers and ability to secure foods from the markets or from other sources such as household gardens or in-kind transfer of food. Also, this part of the food security has been disrupted completely because of the physical access to food, or has faced some of limitations, some of difficulties due to the Israel war and so bad security and movement from region to other to reach and to making some of food has been disrupted because of the bombardment, targeting civilians. This is a very bad situation in the Gaza during the war, so accessibility to food has been completely disrupted. And the third basic elements of the food security is the food utilization, which refers to the individual ability to derive the greatest possible nutritional benefits from the food, as we have very limited amounts and very limited types of food during the famine time. We have not focused on the nutrition, as we have focused on how to satisfy our hunger, how to satisfy the children needs of the food, how to satisfy the vulnerable groups needs about the food. This is the main important topic on how to make the food not to have actually the nutritional benefits of from this food, but actually we have focused here on how to reach and to satisfy the to reach our satiety, or to manage the hunger as possible according to very limited amounts of foods. And the last part of the elements of food security is the stability or sustainability, which refers to the temporal dimension of food security. That is the capacity to maintain the condition necessary to food security. Here is forming and actually discussing the temporal dimensions. That mean we need the time management on how to have a stable and sustainable food for a period of time without having limitation. All of these parts of food security have been disrupted due to the Israel war and due to lacking security in the Gaza Strip. Now we can move to define the nutrition security. Actually, when we want to discuss the food security, we should focus more about the nutrition security, which is the somewhat broader concepts than food security. To achieve nutrition security, individuals need more than just access to sufficient, safe, and nutritious food. They must also have safe water, adequate sanitation, the ability to access healthcare services, the knowledge of sound households and community practice in child care, food storage and preparation, and hygiene. All of these parts have been disrupted, have been very limited resources to reach the adequate sanitation, to live in a secure environment, to have a reasonable hygiene, to have food storage and preparation. All of them have been disrupted, as about 90% of the people in the Gaza Strip have lost their homes and living in the tents. And nutrition insecurity can present various forms of malnutrition. The terms of malnutrition refers to a range of conditions that results from deficiencies, excesses, or imbalances in the consumptions of macro or micronutrients. Actually, when we discuss malnutrition, that we can understand that we have excesses or deficiencies or imbalances, but actually in Gaza Strip we have agreed deficiencies, not only in the macronutrients that making our bodies to be more than, but actually due to have very low micronutrients like vitamins or minerals, which allow people to live in a very bad situation and having imbalances and having micronutrient deficiencies. In fact, as we know, we don't have single nutrient deficiencies. We have multiple nutrient deficiencies. That mean if persons have iron deficiency, that mean have anemia, that have zinc deficiency, that have vitamin A deficiency, that means have multiple micronutrient deficiencies, which affect our lives, which affect our immunity, which affect our functional bodies on how to perform their tasks daily. Here is the pillars of nutrition security, which affects the children in the impaired growth and development. Here is, if we don't have a nutrition security, if we don't have the main pillars that may protect the people from the poor immunity, they may have impaired growth and impaired development, as inadequate breastfeeding, inadequate complementary feeding, inadequate home, living in home, secure home, inability to have food and water, safe water, maybe have poor immunity and recurrent infection. The mother may have not have the enough time and the enough way to take care about their children. If the poor quality of food that just been allowed for the children, that means we should have a poor immunity and poor living and impaired growth and development, not only in the household but also in the community and nation. Maybe the education as disrupted completely due to the war, political economy, agricultural and food system, water, sanitation and environment, healthcare, as many of healthcare services has been disrupted due to the war and inability to access the healthcare services, as well as the society and culture has been completely changed due to the war. The intervention during emergency, what can we do? Actually, we can focus in different parts. We have different programs, but the main programs have focused in the infant and young child feeding during the emergency, and the second, management of severe acute malnutrition and the management of moderate acute malnutrition, which are the main pillars of this presentation and this participation in the conference. What action we can do? We can do also here a treatment of the diarrhea with the ORS, the oral rehydration salts, and by the zinc. A prevention and the treatment of micronutrient deficiencies. We actually have used different types to treat micronutrient deficiencies by using sprinkles, micronutrient drops, by using super cereals, by using the supplements like ready-to-use therapeutic food, ready-to-use supplementary foods, or using other forms of the supplements like the ready-to-use complementary food, and using the psychosocial components of the nutrition that can help to manage the IYCF, which is the infant and young child feeding and management of acute malnutrition. Now we can move to the third part of this participations and this presentation, the infant and young child feeding in emergencies, IYCF in emergency. Actually, we have some of indicators here. In IYCF, we should focus here about the importance of breastfeeding, specifically in the first 6 months of life after the delivery. The first one is timely initiation of breastfeeding in children aged from 0 to 23 months, meaning the children aged 0 to less than 24 months. That means this is very important of us to have to focus on the breastfeeding during the famine. Many mothers have completed breastfeeding more than 24 months because we don't have enough food. So mothers have protected their children from malnutrition. Actually, the mother have received malnutrition and have received thinning and loss of weight, but actually the mothers have paid more attention about their children on how to protect them from malnutrition by completing the breastfeeding. The second indicator of the IYCF is the exclusive breastfeeding for children and for infants under 6 months. That means no other food can be added for the children at this period. And the third one is the predominant breastfeeding under 6 months. That means some of infants have received breastfeeding and have received from commercial formulas, feeding from the commercial formulas, have a mixed breastfeeding with the artificial feeding. And the fourth one is continued breastfeeding at 1 year in children aged 12 to 15 months. That means we cannot move to weaning the children completely, to have a full weaning from the breastfeeding, which is a very important part here in famine, in Gaza during famine, because this have protected many children from malnutrition. This is very important also to make a link between mothers and the children. The second part of the IYCF indicators, the first one is continued breastfeeding at 2 years in children 20 to 23 months. In fact, many mothers have continued breastfeeding and returned back after complete and full weaning for their children, because they have a lack of resources regarding the foods, or have a poor ability to reach their nutrient needs. In addition to that, introduction of solid, semi-solid, or soft food in infants aged 6 to 8 months, which is the first part of weaning. That means the breastfeeding alone in this period is not enough to reach our nutrition needs for the infants. So it is very important to have starting solids or semi-solids food to satisfy the children in their nutrition needs, and to reach their amounts of food that may satisfy their hungers. The third one is consumptions of iron-rich or iron-fortified food in children aged 6 to 23 months, and the last one, bottle feeding in children aged 0 to 23 months, which is completely not good in this part, in this condition, because bottle feeding can results in some of poor consequences for the children, and minimize the link between the mother and the child. Actually, we should focus here about the breastfeeding, about starting the solid and semi-solid food after the 6 months, and focusing on the iron-rich food and iron-fortified food to manage and minimize the prevalence of the iron deficiency anemia, or to nutritional anemia in general. Now we should move to the fourth section of this participation, community-based management of acute malnutrition, CMAM. What are the forms of malnutrition in children? Actually, we can define the malnutrition according to different aspects, but the first one is the subclinical undernutrition. We can categorize it as underweight, which can be defined as or known as acute or chronic malnutrition, can be measured by weight for age. And the second one is the stunting. Stunting can be defined or known as a chronic undernutrition, which is measured by the height for age. And the last one of the phases of the malnutrition in general is the wasting, which is the acute malnutrition or acute undernutrition, which is defined and measured by the weight for height, which is the Z-score that we are focusing in the moderate acute malnutrition, the MAM, and the severe acute malnutrition, the SAM. Now we should discuss the first feature of the acute malnutrition, which is the moderate acute malnutrition MAM, where it can be defined as low weight for height or lengths, less than -2 to more than -3 standard deviation, which is the Z score, a median of WHO child growth standard, or can be measured by the mid-upper arm circumference, that means the MWAC, between 115 to 125 millimeter, and no edema. A child have a good appetite and be alert and clinical well. Actually, if we want to define the Z score and the MWAC, the mid-upper arm circumference, both of them can define the moderate acute malnutrition, but actually due to emergency cases we can use the MWAC, the mid-upper arm circumference, because we have large numbers and we have limited resources to reach the Z score by measuring and by weighing the child, and having the sometimes difficulties to have available length board. But now we can use the mid-upper arm circumference, which is measured easily from the olecranon to acromion end. The last one, which is the severe acute malnutrition, very limited, very low weight for height or lengths, less than -3 standard deviation of median Z score of WHO child growth standard, or we can use instead of this the MWAC less than 115 milliliter, and sometimes we can have complication of bilateral beating edema, a grade 1, a grade 2, and a grade 3, based on the location of the beating edema in the feet, in the lower limbs, or in the generalized body. But actually, if we want to use the Z score, we should completely follow up the children with the Z score. If we want to use the MWAC, we should completely follow up the children by the MWAC, not with Z score. We cannot mix between of them. The first part that used to diagnose the children with the malnutrition, we should use in all of follow-up. What are the components of the CMAM? The first one is the community outreach, screening children using the MWAC. The first here is regular mass screening, active case finding, referral to treatment sites, and follow-up of the defaulters. Due to poor security and poor transportation in the Gaza Strip, many families cannot reach the facility of the treatment, so the outreach can help manage and find the defaulters and find some cases of malnutrition. This is very important part of the CMAM protocol and for the CMAM management. Active finding of cases. Actually, the MWAC can help all persons on how to find the persons who have receiving poor attention from the community or from the health providers. So the first part of management of the CMAM is the community outreach. The second part is the outpatient therapeutic program, OTP, for the SAM without complication. We should focus here. The SAM without complication. The SAM with complication should be moved and should be referred to the stabilization center. The admission criteria for the SAM without complication here is the MWAC less than 11.5 centimeters, or weight to height z-score less than -3, no edema or having edema in the first or the second part, a child is clinically well with appetite. Here the condition used for the children between 6 months to less than 5 years. How can we deal with these parts on these children who have severe acute malnutrition? The treatment by using the ready-to-use therapeutic food RUTF, which is a plum peanut, 2 sachets per days, and routine medication using in the first week of the after the admission amoxicillin, and in the second week using albendazole for deworming, using vitamin A except in case of edema because it is may have toxicity for the liver. Use ready to use complementary food, the mixed fruits and vegetables for children who were between 6 to 24 months. So this is very important. All children from 6 to 5 years should have ready to use ready to use therapeutic food. All children between 6 months to 2 years should use the ready-to-use complementary food in addition to ready-to-use therapeutic food RUTF. If any child has a complication, we should refer this child to the inpatient care or to the stabilization center, who can manage or who can be sent to the admission criteria of the stabilization center for the children between 6 months to less than 5 years. For the some with complication, what are the complications such as anorexia, severe infection, severe dehydration, hypoglycemia, hypothermia, pneumonia, sepsis, shock, severe edema in the third grade? How can we manage these cases? By the treatment, we need 7 days in the first phase in the stabilization. We can use the formula F75. F75 can provide 75 kilocalories and 0.9 gram of protein per 100 ml of the milk. And after that we can move to the transition phase. Also this is inpatient as the first phase, which is inpatient. We can use here the F100 formula. F100 formula can provide 100 kilocalories and 2.9 grams of protein per 100 ml, and or ready to use therapeutic food. One of them is enough, but we can use the both of them depending on the case, depending on the situation and the clinical situation of the child. And the third one and the second phase, depending on the how as the child received the treatment, how the child received the attention. Actually we can use here the 100 formula, or we can use or the ready to use therapeutic food, which actually this is a rehabilitation, which is very important to use ready to use therapeutic food to completely manage after that by ready to use therapeutic food. The main disadvantage of the ready to use therapeutic food is the diarrhea, but actually we can manage the diarrhea in case of the other reasons that affect the child to have the diarrhea. But in case of the diarrhea results from the use of RUTF, we can use the RUTF in separate times a day, not to use as a one meal or a sachet of that, because one sachet of the RUTF can provide about 500 kilocalories, and the two sachets can provide about 1000 kilocalories, which is very important as in famine we have very limited food sources that to satisfy the need of the children. The fourth part of the CMAM is supplementary feeding program, the management of MAM. Here is the admission criteria for the MAM. The MWAC is between 11.5 to 12.4 centimeters, or we can use the z-score of weight to height between less than -3 to more than or equal -3. No complication here. We can use the RUTF1 sachets per day for children less than 5 years. We can use also 3 jars per day of the RUCF, the ready to use complementary food, and we can use the fortified blended food like super cereal plus, which is very important to manage malnutrition among women who were pregnant or lactating, that can take by the woman herself or by their children, or can be used for all family members to manage malnutrition. Here is the discharging criteria. If the MWAC reaches more than or equal 12.5 centimeters, continued for 2 consecutive visits, no edema for 2 weeks, and the key monitoring indicators: a curing rate more than 75%, default rate less than 15%, death rate less than 10%, non-response rate can be managed accordingly, average length of stay and average weight gain target more than 8 grams per kilograms a day. That means the children have received a good discharging criteria and good monitoring indicators. Now we can move to the fifth section, which is rights-based approach versus the charity. Rights-based approach versus the charity. A clear difference exists between a right-based approach and one based on the charity. The latter see the words hungry as and malnourished as a passive recipients of handouts from the states or the benevolent individual or groups, whereas charity depends on the moral will and compassion of the givers, who chooses to provide the food to people who are hungry or who suffer from food insecurity. A rights-based approach regarding hungry people as active citizens deserving of respect and dignity. Here is a big difference between the two terms, the charity and the rights-based approaches. The rights-based approach is founded on the belief that hunger and malnourished are largely the product of man-made injustice, sometimes compounded by random factors such as natural disasters. Here is the purposes of the United Nations. We can review why is the United Nations has been established and has been initiated to serve and to help people. And also we have here the article number 55 of the Charter of the United Nations that focuses on universal respect for the observance of human rights and fundamental freedoms for all without distinction as to race, sex, religion, or language. This is very important to understand for everyone in the world. And finally, we have reached the sixth and the last section of this presentation: what may happen in the future about the nutrition transition we are speaking here. In nutrition transition and food environment, there are five historical patterns and changes during the nutrition transition. The first one is collecting of food. Hunter-gathering ate a diet high in carbohydrate and fiber and low in fat. The second one is the famine. There were a period of acute scarcity of food, a little dietary variety. These changes are related to the adoption of lifestyle based on the farming. At first, food mainly consisted of crops, but later also included livestock and poultry. Receding of famine as farming development, there was increased consumption of fruit, vegetables, and animal protein, and less reliance on starchy staple foods. And the fourth one, the nutrition-related chronic diseases of lifestyle and increased availability of inexpensive processed energy-dense food high in fat, cholesterol, and refined carbohydrate named Western diet. And the last one is the behavioral change, increased awareness about physical activity. Actually, we have moved from one to one, from one period to other period. We have a very scarcity in food availability during the famine, but after that we have receding the famine as we have focusing now in consumptions of fruits, vegetables, and animal protein as some of types of food have been finally available. But now our fearness that we can transit from the nutrition scarcity to nutrition and to high food availability, that moving from undernutrition to overnutrition. This is very important to focus on in the coming days. Because of that, we can discuss the double or the dual burden of the disease in low and middle income countries. In recent years, there has been a great deals of urbanization and economic development. Following this, the nutrition transition has been rapid and intense. The result is that the chronic diseases of lifestyle, especially obesity, hypertension, cardiovascular disease, and type 2 diabetes, emerged in higher socioeconomic groups. Before the battle against undernutrition and infectious disease in the lower socioeconomic groups had been on. This coexistence of chronic diseases of lifestyles in adults and infectious disease mostly in children is known as double burden of the disease. This is very important topic. This is we should focus more in coming future. In coming future, we can see the chronic diseases of lifestyle among adults, and we can see the infectious diseases among the children. But the most dangerous thing, if the children who have poor immunity, having multiple micronutrient deficiencies, having in the future the chronic diseases of lifestyle and having overnutrition, because we having overnutrition, obesity, diabetes, hypertension, and cardiovascular disease. At the same time, the same person may have the micronutrient deficiencies like vitamin A deficiency, like iron deficiency, like zinc deficiency. A particular feature of this that the onset of the chronic diseases of lifestyle in the adult population occurs at a younger age than in developed population who experienced the nutrition transition many years ago. Also, the consequences of mortality from chronic diseases of lifestyles are more pronounced in population who are presently experiencing the double burden. A possible explanation in that in countries experiencing the double burden undernutrition inducing early fetal and infant programming, which then confer an extra vulnerability of chronic diseases of lifestyle in later life when these programmed individuals are exposed to the Western diet, and the Western diet, which is known as a high calorie diet and high empty calorie diet, that rich in calories but have poor content of the valuable and high biological value of protein and vitamins and minerals. The double danger of the early nutrition, early undernutrition poses a double danger to human health. There is a danger of increased risk of chronic diseases of lifestyle during adulthood. Babies and infants who are nutritionally compromised have a greater risk of physical and mental cognitive underdevelopment. This is very important and very dangerous part of the early undernutrition. This is often termed as a decreased human capital. Adults also grow up in such situations are unable to build a better life and escape poverty. They will move in a vicious cycle, in the poverty cycle, from malnutrition to poverty, from poverty to malnutrition. So they are moving in a vicious cycle, and the community at all will face the poverty and facing very poor living conditions. The consequences of this is an intergenerational poverty malnutrition cycle. These serious negative consequences of early nutrition have a profound implications for nutrition policy and programs. We should focus in this part. We should focus from the food transition from undernutrition to over nutrition to manage the coming generation and how to manage the major capitals of this population. Here is the end of this presentation. I wish if I have successfully explained the situation of malnutrition in Gaza during war. Thank you very much and goodbye.